Hello, everyone, and welcome. And thank you for tuning in to Health Leaders, the place for peer-sourced and solution-focused insights for healthcare executives. My name is G. Hatfield, and I'm the CNO editor for Health Leaders. Today, we are speaking with Nicole Telhiard, who is the Chief Nursing Officer at Our Lady of the Lake Health, about an innovative sepsis protocol that is helping drive down sepsis mortality rates. So, hi, Nicole, how are you?
Hello, I'm good.
It's good to see you. Thank you for dealing with some technical difficulties at the beginning of this. I appreciate it. So first off, can you tell me a little bit about the role that nurses play in sepsis detection and prevention? It's a pretty big issue, so talk to me about that.
It is, and I'm very proud of the role that our nurses play in our emergency room here at Our Lady of the Lake Health with sepsis. We've had an interdisciplinary quality work group that's met for several years about sepsis and those pieces. And what we learned from the voice of the customer and really listening to the frontline nurses is that they were getting some tedious, we call them BPA fires in our Epic platform. And about 90% of those were just fires that the nurses weren't really acting on or reading. And that's some data and analytics that we can work through. So, through listening and understanding some barriers to that, what we learned was we were not really using their expertise to the fullest. So we implemented a new advisory that really is nurse-led, nurse-driven,
Mhm.
and was a group effort between our physician colleagues, Dr. Chris Thomas, Dr. Jagno, Dr. Laprousse in our emergency room, some key physician leaders, and then our nursing ED director, Sonia Willis, came together with other interprofessionals in pharmacy to talk about two key questions that might be better than the BPA that was firing based on clinical documentation. These two key questions allow the nurse to use their expertise and their input. The first of those questions is asked, is the patient presenting with an altered mental status? And then the next one is just simply, do you, in all of your expertise, feel like the patient is presenting with suspected infection? And after answering those questions, it then goes through some of those other cycles of clinical data that we were using to really formulate and help us initiate our sepsis protocol.
Absolutely. So what were kind of the core concepts and goals that you had when developing the protocol? What kind of pain points were you really trying to hone in on?
Yes. One of the biggest pain points is really unnecessary testing in the past that we
Mhm.
were doing. Traditionally, when patients came in with sepsis, nurses would have to draw blood cultures. Those were waiting on our physician orders to implement and order those. Then the time that it took the nurses to go and draw blood cultures, and then you waited more time on blood cultures. And
Mhm.
so some of that was really what we found unnecessary. Um, but it took a lot of time on the nurse's part to draw a sterile blood culture and do it well. And those were things that we were measuring is cleanliness and sterility of our blood culture process with nurses. And so what we learned through this clinical protocol, very similar to how we handle STEMIs, heart, chest pain, and those things in the emergency room, very
Mhm.
similar to how we handle stroke patients in the emergency room. Our nurses had already had very core, solid processes for how we handled those two patient populations. So
Mhm.
as we started this journey with sepsis and letting the nurses take a more active, engaged frontline work in that we were able to, through this work, just off of their plate, save them some time to refocus as a broad piece throughout all of our emergency room patients by not having to draw unnecessary tests and have unnecessary treatments in those pieces. And really focus on the work that our telesep and our sepsis protocol has done for us is really have the nurses focus on that high acuity patient, the patients that are really sepsis, focusing on them with time management and time intensity and getting in front of them and really being part of that interprofessional team.
Mhm. Absolutely. And it's good to hear that it's saving time because, as we know, nurses could definitely use that. So,
Yes.
yeah. So, how does this protocol change the typical nurse workflow during triage? Like, what changed from before and after the protocol?
Yeah, so when the protocol, when they answer questions and a BPA now fires, They can implement, we have approved by our medical executive committee a sepsis protocol that the nurses can go in and start that protocol, start drawing the lab work. And by drawing the lab work and implementing the testing for that IntelliSep test piece, we now have data better and quicker at our fingertips to know these patients are septic, these may have other infection but not septic, or have other things that we then need to work through with our physician colleagues in the emergency room. So that in itself of being a time saving, not waiting and delaying for other comprehensive panels and cultures and those things to take time has really been a tremendous help for the nurses. What we've seen is by really including them on the front end and listening to them in an interprofessional way, having them feel part of this full team has really helped them to improve the morale in the department and improve their time that they have to spend and really work more interprofessionally with our team.
Mm-hmm. Absolutely. And you mentioned data. So I wanted to ask you, what outcomes have you seen so far since implementing the protocol, specifically with mortality rates?
Yeah, sure. So we do have some data. We've seen our length of stay and the time that patient stay in the hospital has decreased. We have seen our revisits, which is one big piece of the emergency room visit. We're accurately testing and screening people appropriately. So we have seen great success with patients not having to revisit or bounce back, if you will, repeat multiple episodes of ED visits. We're having a much more accurate perspective of what's going on with them on that first ED visit versus repeating multiple visits within a 7 or 10-day period that we're very excited about. And then lastly, one piece that we're very excited about how this work flows through when you leave the ED and you get admitted, and then you're out on our med-surg units or our critical care units. Another big clinical protocol that we've been collaborating closely with our physician colleagues on is our early mobility protocol. And just having this information and learning how the nurses use these protocols and some best practices from this protocol helps us to make sure that we have patients up on the units moving around earlier and getting out of their beds and sitting in their chairs to eat and those things. And it's helped really the full perspective of nursing care and interprofessional care at Our Lady of the Lake by transitioning these from just an emergency room function across the spectrum of healthcare.
Mm-hmm. That's fantastic. And my last question for you is, do you have any advice for CNOs who might want to develop a similar strategy in their own health systems? Because clearly it's being successful for y'all.
Yes, I'm a very large proponent of interprofessional teaming. So I would say, make sure that definitely include your frontline staff. That was critical for us. I mentioned some of our key leaders that were part of this process, but I can quickly visualize the charge nurses and the nurse supervisors in the ED that wanted to have an input into this piece. So including frontline staff, shared governance, which many CNOs value that work, is very important to this process. And then just continuing to follow up and remember it's a journey. It's not an overnight piece, but by spending the time with your frontline leaders and your charge nurses and listening to their voice and letting them be part of the decisions and part of the workflows in their departments has been instrumental to us. And then just removing barriers. It's critical to the role of the chief nursing officer to remove barriers. When we first started some of these protocols, we had some things that nurses can't do that, or we can't do this. But our medical executive committee has been very supportive of collaborating with us and having those protocols reviewed and oversight of those protocols on an annual basis so that we're all singing from the same page.
Absolutely. Well, thank you so much, Nicole, for your time. I'm really grateful to have had this opportunity to hear your insights and get to know you a little bit. And thank you so much to our audience for listening. Thank you, Nicole.
Thank you. Take care.